carry on. Sorry.
No, I'm glad you remembered before we got started. So it's always a good thing. Yeah, so I'm going to talk about PIPCHE community, the community outreach core, exploring social factors relating to preventive cancer screenings for Native Hawaiian Pacific Islander adults, sort of lessons learned along the way and my future directions for everything. So again, my name is Mark Willingham. I am a first generation Mexican-American college student. I am a PhD candidate in sociology. I know, what are you thinking? What's the sociologist doing here? I like thinking of myself as like a cousin to public health, all of the work that I do. My focus is in medical sociology and healthcare utilization, preventive health. That's kind of what I've just kind of navigated towards as far as my career. So funny enough, I started out with in criminology. So my background's in applied criminology, but I saw this sort of public health approach to incarceration that really sparked an interest. And from there, I've kind of just navigated towards more health, and all of a sudden it's like cancer screening. So that's where I'm at now, and I think that's going to be the future as well for me. So funny career track, but I've heard from a lot of people they have those sort of interesting career tracks to where they're at now. I'm, like I said, I'm at the University of Hawaii Cancer Center in Honolulu on Oahu. I'm a community health educator. I've been here for the entirety of my PhD program. So I started off as a graduate research assistant. I'm a research associate, and I'm a community health educator working on a larger grant. I'm ABD, so I'll be finishing up hopefully, if not the spring, fall of 2023. So just a little bit over a year left for my degree. So this is my work for that. But I also am working on a Medicaid 1115 demonstration waiver from a state evaluation, which has been really interesting to learn more about the insurance side of everything, especially with health. I know some of you all who work in the medical field know a lot more about that, but it's really interesting to learn about, how the state is approaching healthcare and whole body care when it comes to, well, for us, we call it MedQuest. So Medicaid is what we're doing for that evaluation. I'm working on primary care, value-based purchasing. It's a lot of interesting avenues when it comes to healthcare and, health equity. So my work has been interesting with Native Hawaiians and Pacific Islander communities, such as like Chuukese, Marshallese, Palauan, and other communities as well as branching in the Filipino community, because we see huge, health and cancer disparities in those populations here and all over the world. Things like cancer behaviors, cancer screenings, health literacy, health knowledge, barriers to healthcare, cancer screenings has sort of been the focus of my work, the time I've been here. With a little over 8 years working with historically excluded populations and health disparity issues along the way. So to go into like my role with work and what that starts with, so it stemmed from this Pacific Islander Partnership for Cancer Health Equity. I'm not sure if you all are aware of that. It's what we call it U54. It started in 2003 with the University of Hawaii, University of Guam, really trying to explore the reasons behind significant cancer health disparities among Pacific Islanders in Hawaii, Guam, and neighboring Pacific Islands. So this is actually the third iteration of this grant. It's a 5-year grant. It's gone through a few different things in the beginning, but it's a great partnership between the two sites working on these sort of cancer health equity for populations who have been traditionally left out of sort of, the focus of cancer health. It's one of only 16 National Cancer Institute's partnership to advance cancer health equity. And it's the only grantee serving Pacific Islander populations with emphasis on Micronesian communities. So that's really what we focus on within this partnership are those communities within Pacific Islanders. And that's like our first meeting that we had in person since COVID. We had just recently here, and the next one's actually in Guam. So it goes back and forth between the years. But we're going into year 3 of the 5-year grant of this cycle. But the aim sort of driving this work is really this overarching goal to promote cancer health equity and sort of mitigate the impact of cancer on Pacific Islander populations through increasing cancer research, leadership, and capacity in Hawaii, Guam, and the United States Pacific Islands. As the only NCI-funded partnership serving the underrepresented Pacific Islander region, the aims really are just to kind of continue to develop a portfolio of Pacific Islander population-focused cancer research, including clinical basic population health sciences, collaborate with local organizations, local partnerships to really promote that type of cancer health equity within those organizations and enhance opportunities for research training and workforce development, not only through the researchers, but through the community as well. Sustain, strengthen, and evaluate all of partnerships goals. So everyone that goes through this has to come talk to us, which I'll get into that structure in a second. Enhanced evidence-based relevant cancer research interventions, and really just expand the scientific collaboration within the entirety of the grant and those working within it. So like I said, I'm part of what we call the Community Outreach Corps. So so PIPCHE really has a structure of the two sites, University of Guam, University of Hawaii. And within that, they're funding multiple different research projects, bigger research projects focusing on things like betel nut, liver cancer, other aspects like that, really dealing with these communities, Pacific Islander communities in location in Hawaii and in Guam. But within those, we have like a biostats core, a research education core that works with graduate assistants to kind of work with them to work on various parts of the project through the research, build up their talents when it comes and their skill set for working in the field later on. But we're part of the community outreach core, meaning we kind of think ourselves as the bridge between the community and the research that's being done. So every one of the research projects comes to us in the beginning and helps with, things like recruitment flyers. We help them with that as well as strategies for that. We meet with the course throughout the time to talk about how that's working for them. If they need help with, partnerships or navigating that with community or different organizations, that's kind of our goal. There's us in Hawaii and us in Guam. We assist and promote the research. We build Pacific Islander population serving healthcare providers competencies, which I'll go to in a second as well. We help, train the new cadres of researchers by working with students a lot of the times and ESIs, early stage investigators within the core. Really, our long-term goal is to reduce cancer barriers leading to cancer disparities in Guam and Hawaii, specifically among Micronesian and Filipino populations to achieve health equity. So this actually was the first grant cycle where they brought in, it was just Micronesian communities, but now they saw within our most recent, cancer health information and statistics that Filipino communities were at a huge disadvantage when it comes to cancer as well. So we brought in that population to the granting cycle to really focus on those communities to really help increase some of that education around cancer screenings and hopefully get those, better health outcomes for that community. And so this is the community outreach core, us, and the picture right here is actually the folks in Guam. They're the ones who are also working in Guam. We have the investigator, Dr. Samara, and lead investigator, Dr. Diaz, as well as community health educator, Angela, and then Harmony, who is the research associate there. And on the Hawaii team, it's myself, the community health educator, Dr. Castle, who is the co-investigator for everything. And then we have Dr. C and Manura Tafaki, who are the co-investigators with the project. And this kind of breaks down like what that looks like. So we provide flyers for everything kind of going on what we do as far as the work that we're trying to do. So most of our work really now, especially since COVID was shifted, right? The news cycle started around when COVID began. So we had to figure out how we're going to do community outreach. Like I'm sure most of you have dealt with that as well. Like how do you outreach when we're stuck inside? So a lot of that was just reaching out to federally qualified health centers, reaching out to providers, reaching out to the networks that we had, offering services via Zoom as far as cancer screening, education, we actually worked on a health provider symposium for the Pacific. We put on last year and had almost 100 attendees through various islands in the Pacific, which was a great thing. We have to do another one next year, which will be in person here, but the last one was virtual. We just found it to be a great way to talk about COVID and cancer. And especially as we were kind of coming down from COVID, how can we work on increasing those screening rates? We saw that huge dip in cancer screenings during COVID, which is expected for people not going out. But a lot of the thing we do is really education focused as being on the outreach course. So you can see in some of the photos I have, this is me in a public housing area around on the island, going out and doing, pop-up shops about colorectal cancer screenings, information about that, as well as ways to increase the different type of screening options, individual risk factors, all that kind of that information there. That's what this is a table in Maui I worked on last month as far as providing resources for individuals during health fairs. Again, it's so great to go back out in the community, being an outreach core, especially since May. I've really kind of hit the ground running again with outreach, and I have a long list of the different community events I've been a part of as far as wellness fairs and events and going to churches, which I'll get into that all as well. But it's really been great to go back into the community and work on that because, like I said, dealing with health equity, everything we do has to go back to the community, has to be for the community. And that's what we try to do within the COC, the Community Outreach Corps, is ensure that we are, bringing them to the forefront and the focus of everything that the partnership does. And it's informed by the community. So I'm sure as most of you are aware, Pacific Islander Health, there's, we see a very underserved communities at times with large cancer health disparities and health inequalities in the communities. it's really underserved minorities with significant cancer health disparities compared to the US overall. Native Hawaiians and Pacific Islanders, represent about 0.4% of the US population. Of that number, about 355 Native Hawaiians or Pacific Islanders reside in Hawaii. And with that, we see a lot of, like I said, health disparities. And each year, an average of 7,393 Hawaii residents are diagnosed with invasive cancer. And then on average, almost 2,400 residents die of cancer each year. So we really try to talk about that information to the community because a lot of people don't really realize these numbers, what it looks like, what cancer looks like in Hawaii. And that's what we're trying to do, is really increase that knowledge and awareness of cancer, and also work on improving screening education with our partnership. Micronesians have some of the highest incidence of cervical cancer in the US. And a big thing that we see, and I'm sure most people know that with, especially when we talk about like Asian American populations, is that whenever we talk about these populations, they're often aggregated to Pacific Islander or Native Hawaiian Pacific Islander, or even Asian American Native Hawaiian. And that really masks true cancer health disparities. That's a big problem you see in the research and the literature. It's something that we really kind of drive home, that it's hiding some of those really true cancer health disparities and what those figures may actually look like. Oftentimes you have to like reach out to sources to ask for that disaggregated data, and it can be problematic because you don't really know what's going on. So that's what we try and, talk to when we're working with other people, especially outside the Hawaii mainland. We talk about the importance of disaggregating that data. And a lot of the different things that we've seen as far as cancer controls, cancer interventions, things like that, it's not really aimed at specific populations, and that's the problem, right? Future cancer control initiatives designed to specifically address Micronesians and Filipino communities. So they don't work, right? We bring it out here, it doesn't really make an effect if it isn't really tailored toward that community. I know you all know that in the work that you do, but that's something we try and reiterate when we're talking to that with different organizations, different, especially from the head up hierarchy, talking about the importance of that disaggregated data, and also really how we have to tailor things to meet the needs of the community. So some of the work that we're doing here, like I said, the NCI Screen to Save colorectal cancer screening and outreach. And you can see there's a photo of me doing that out. And that's actually at a restaurant in Waipahu, just setting up outside of a Micronesian Marshallese restaurant, grabbing people and talking about the importance of cancer screening. But it's a great thing. It's so Screen to Save is, if you're not aware, it's just a really quick intervention as far as like having them do a pre-test about their knowledge of colorectal cancer, and as well as screening methods. Going into a introduction of a presentation of what colorectal cancer is, different types of risk behaviors, risk factors for that, different types of screenings you can do, and as well as just individual risk factors, things like I said, just really how a really quick 20-minute introduction into that and what it looks like, and how you can work on that cancer screening, when you should get in, who should get it. And they do a post-test after that to see if their knowledge increased about the education that we provided them for colorectal cancer. So it's just something small we can do that we kind of focus on whenever we can at different events. You can see that's me actually doing a presentation at a church. It's a Two Keys Women's Church. A lot of things we have to do is very low resources, low technology. So we have a tabletop flip of all of those, small and large. We have one for clinical trials. We have one for HPV. We have, of course, PowerPoints for everything, but when you're out in certain in the field, you have to have that sort of like tabletop presentation ready to go, because again, the technology may not be there. So we have to try and work with them and provide education as much as we can through whatever resources that we have. We're also working on a statewide clinical trial survey that kind of assesses knowledge, attitudes, and behavioral intentions towards participation in clinical trials. As you know, a lot of people don't really know much about clinical trials. People have a lot of wrong information when it comes to clinical trials. They don't even know what that is. So we did just a quick key informant interview on each of the different islands of Hawaii to talk about what providers know about clinical trials, how they think we can best increase the knowledge of patients to be involved in clinical trials. So working with on that right now, it should be going out next month to work on getting our number of surveys for that, to kind of just really know more about clinical trials in Hawaii, because as most of you probably know, we have multiple islands. We're trying to learn as much as we can through that, hopefully through that survey, which will be going out in the next month or so through an organization. We do a lot through community outreach. Like I said, we're out at multiple organizations now, which has been great. I went to Filipino Fiesta, Australian Women's Day, Two Keys Church, went to Maui Wellness Fairs, Hawaii Community Healthcare Worker Conference. And I know I hate photos of myself, but I'm the one out there doing it right now. So you'll see a lot of photos of me, and I apologize ahead of time. But yeah, I'm just doing as much as I can to get out there and talk to the community, especially coming from a cancer center. a lot of people don't realize what we are, what we do, what we're trying to do. So I've found that I am doing a lot of really talking to people about losing my voice too. Talking to people about what the Cancer Center does, because people don't really realize that. And what I found, especially on the neighbor islands. So we're really trying to provide resources about the Cancer Center, about studies that what's happening, about, recent figures, just really trying to educate people about the importance of the Cancer Center, but also the work that we're doing with the Pacific Islander populations. We're also working on healthcare provider training. As you know, most of the stuff that we do is really based on individual risk factors and, increasing health education. But we also decided with this sort of 5-year round of the grants partnership that we really wanted to work with healthcare providers, because we can't just focus on those who are receiving care. We have to work with those who are providing the care as well. So we work with them on a cultural competency training with working with Pacific Islander populations, which I'll show you a few slides after this of what that kind of looks like. And I'm using multiple screens, so let me know. Feel free to stop me and ask questions if you want to wait to the end, whatever works better for you all. If it's something pressing on your mind, just let me know. And feel free to speak up. If I miss any hands or comments, I apologize. We also do everything through, we filter everything through our Outreach Advisory Council, which is a photo here of one of our most recent committee members, of course, virtually. We have about 10 individuals who are part of the Micronesia community, Pacific Islanders, and Filipino community. Of course, attendance kind of varies on the different meetings, but we meet with them at least twice a year to talk about, what we have planned for the year as far as our outreach efforts, what we plan on focusing on as far as, the different type of initiatives that we're working on. We gather their input, they provide us feedback, what they think we should do. We also bring them any type of the research projects has flyers. We bring that to them to see what they think, if it's actually capturing what, the project would like to do, if it's missing anything, just really trying to run everything we can by them through our meetings and through emails. And they've actually been great with our work of trying to get out to the neighbor islands, because like I said, everything in Hawaii is really Oahu centric, right? Honolulu, everything is focused here. We oftentimes forget about our neighbor islands. So they've been a great connection to that because they're also part of the Maui Nurses Association. So we've been able to go out there for some different initiatives to work with them and hopefully to go out to the other islands as well in the future. That's been a great resource through our Outreach Advisory Council. But really, they just act as really a guide for everything that we do, and we bring to them everything that we plan on working on. We've also published with them, or we're trying to publish with them. We put together a manuscript because like I said, this was our first time working in the Filipino community. So we wanted to reach out to them. So we did needs key informant interviews with about 6 members of the community who work with nurses, health providers. And we worked with our Outreach Advisory Council to put a manuscript together about that process, findings from that as far as what they see as hindrances to health for the Filipino community and, cancer initiatives. And we think it's important to have that sort of community-based participatory research. So there are authors on the papers that we work with as well, our Outreach Advisory Council. And I definitely recommend that as much as you can to ensure you're using that community-based research as much as we can. When we're talking about health equity, right? Let's bring all parties to the table and do everything that we do. And that's what we're trying to do with that. And present that to in conferences as much as we can. I'm often like this sole person at a conference talking about, Pacific Islander populations. But just trying to really bring those issues to the light on the mainland as much as I can to individuals and people. So with that provider training, it's titled Improving Quality of Healthcare Through Cultural Competency and Understanding Cultural Differences. And it's really, I know there's a lot of cultural competency trainings out there. Most people have to have that for their organization, but ours is focused primarily on Pacific Islander populations. So with that, I kind of provided the agenda of that. So I go through what PIPCHE is, what we're doing, what is cultural competency, the need for culturally and linguistically appropriate services, or those sort of class services that are really as standards for use in the office, Pacific Islander culture, values, and beliefs that we've collected through different type of projects, different type of interviews of people, members of the community, cultural perspectives on healthcare, expectations, challenges, and communication within Western healthcare, and cultural competency within the healthcare. That's just kind of like the agenda of what that training looks like. So I kind of go into, what is cultural competency, really how it's seen as a, foundational pillar for reducing cancer disparities, or really all health disparities through culturally sensitive and unbiased quality of care, which is defined as care that respects diversity in the patient population and cultural factors that can affect health and healthcare, such as language, communication styles, beliefs, attitudes, behaviors. And really just kind of talk about how this is needed really in healthcare, and it's seen as something that's, taken off in insurances and all type of, fields in the world, because they see how how culture really defines actions and beliefs, and that can sometimes come to heads with one another when you're working with people who are within different, cultures as your own, especially in healthcare. And this, like I said, this isn't just ethnicity, race, right? It's also persons, populations such as persons with disabilities, LGBTQI plus. The list can go on and on, but it's really the need to paying attention to that and within, the office environment when healthcare. I also go into like the different role of cultural competency within the organization, kind of highlighting the role of how, when talking about cultural competency, right, it's a continuum, it's something to strive for. And even things like organizations, healthcare organizations, they can be at different parts of that continuum. Your staff may be working really well with them, but that may not be the same when they actually go to see the doctor. So that can kind of destroy the whole interaction if, they're not being respected or their needs aren't being taken care of because of the sort of cultural differences. So I kind of go through that with them to explain that and really just talk about how organizations can be large and fluid, and organizations have a culture in and of themselves as well, right? We know that, every place has a culture in your organization. So it's important to know that and how that can influence behaviors, unbiased and biased and unbiased behaviors, and that can be implicit or explicit sometimes. The importance of having those like sort of culturally and linguistically appropriate services within the healthcare. I kind of go into that and offering some Office of Minority Health has a great class standards for that, which kind of provide a blueprint for really incorporating that into the office. I'm sure most people already have that, but just kind of reiterate that as far as, having that signage available, having forms available, knowing your patients beforehand, as far as, the ethnicities that you most likely will see, having those forms beforehand, having interpreters, available so that there aren't any sort of languages mishaps along the way, can really help to improve with staff, their cultural competency, services they provide, quality of services, but also increase client satisfaction and increase client engagement and the client experience overall. And I also think it's important to kind of make everything well-rounded, right? So I don't want to just talking to them about cultural competency, but I also bring it to them what I've learned from talking to, members of the Pacific Islander populations about, hindrances to healthcare. We talk a lot about patient navigation. People don't really know how to navigate the healthcare field, especially when we're talking about people who English isn't their first language. A lot of folks are recent migrants. People can come, part of the COFA agreement is they can kind of come and go without having to have a visa. So we're not even sure who's always here. There's not some sort of, list to talk about how many people are here and what they're doing. So we don't really know the true factor of how many Pacific Islander population people are here. So there's always a challenge of trying to navigate a new system of, language, a new system of care. And people oftentimes get confused and don't even take part in that. And that's what we've seen of preventive care. It's not a thing people engage with because they don't really understand how to navigate that system. As well as the need for cultural sensitivity. Past experiences can really influence behaviors. Things like mistrust in healthcare, historical trauma can all lead to not wanting to engage in healthcare at all, especially with the Pacific Islander populations with, the history of, nuclear testing and everything that's been done of taken land and stolen land. Uncomfortable exposing body parts. We talk about the importance of gender matching. Like myself, I would never talk to a group about things like HPV or, the importance of mammography. Like I focus on colorectal cancer because we find it important to gender match as much as possible, to respect everyone. Healthcare provider priorities, interpreters, of course, some people rely on family members as much as they can. There's also really belief and trust in God. We found that to be a big thing with the Marshallese community when it comes to health and cancer, put it up to God, but we believe in God. So really trying to navigate, talking to them about the importance of healthcare, but respecting that as much as we can, because that can really be a guiding belief about healthcare with supposed language barriers, transportation, childcare, insurance, lost documents, work schedules, right? There's a lot of things that can kind of influence people's decisions on engaging in primary care. So a lot of times it's more reactive versus proactive. So that's really our focus on that sort of cultural competency within healthcare. Like I said, it's not just about the individual. We want to work with those who are providing the care. I just did one the end of last September with over 50 people from a health center. So it was great to, talk about that with them, what we've learned from our interviews and surveys with different people of Pacific Islander populations. So I have about 5 minutes left, so I'm not going to go too much into my research, but just to let you know, so really what we're trying to do is how to better understand the knowledge of and attitudes towards and use of cancer health related information and behaviors when it comes to cancer screenings. So the Cancer Center took part in I'm not sure if most people may know the Health Information National Trend Survey, which regularly collects nationally representative data about American public's knowledge of, attitudes towards, and use of cancer and health-related information. It's really a way to kind of monitor change about, health communication, health trends, health information. So it's been around since 2003. It really provides updates on changing patterns when it comes to information, communication, healthcare, and cancer information. Like I said, it can look for trends, assess cancer information, access and usage, offer a test bed for database for researchers to really test theory and health communications. So this is actually a great thing for us to use. So, however, with most, national surveillance data, they aren't kind of addressing the needs of unique demographics, such as like Native Hawaiians and specific kind of populations. So we're not really sure. Those populations are often left out when it comes to those really bigger national data sets. So it's not reaching these historically excluded populations. So the UH, my PI, Dr. Castle, and some other folks decided they wanted to kind of provide a P30 supplement to use hints, but also learn more about what that looks like, here in Hawaii and in Guam. So they had a goal of recruiting 500 Native Hawaiian, 250 Chuukese, and 250 Marshallese individuals. So between 2017, 2018, I came on and we actually recruited 1,010 individuals. We use respondent-driven sampling, which is sort of like a snowball sampling methodology where, you talk to someone, they provide the survey and they can refer 3 people to you. So you can follow like a chain link of the sampling methodology for that to really see if that can help increase the usage, the number of participants we can get. And you can also look at like what that looks like as far as the sampling. We recruited from 3 public housing locations, churches, and community organizations on Oahu here. Just to give you an idea of that, we published this information as far as like the sample demographics, but we had 1,010 people take that. Most participants were young and female, 61%, with a mean age of 44 years. 75% completed high school. Lower income levels were 39%, which we expected because we were at public housing, spots on the island. 85% had income less than $35,000. 54% did have insurance. 76% of Native Hawaiians compared to 58% of Marshallese, and 52% of Chuukese identified with American customs. So the big finding that we found was that controlling for age, we found that Chuukese and Marshallese were more than twice as likely to trust health information from their religious leaders than their own physicians. That was a big finding, to find that, these communities were really more trusting in their religious leaders than their actual healthcare providers, which we all assumed was the case, but this kind of highlighted that information. I did some geocoding so you can see what that looks like as far as pockets of where everyone was when we did the survey. So my interest really is in cancer screenings, like colorectal cancer screening. We found a huge discrepancy. Only 37% of participants completed colon cancer screenings. If you're looking at Hawaii as a whole, 75% of respondents reported doing that. So we see a lot of people did not engage in that sort of screening they should have. 52% have, so we see only, 50% of participants had a mammogram within the past year, whereas 80% of Hawaii residents reported that there's a discrepancy. Cervical cancer, again, we see a huge discrepancy of the people who actually reported engaging in that screening versus looking at Hawaii as a whole. So like my research that I'm doing for my dissertation is I want to know why there's such disparate rates. What are the hindrances, obstacles to healthcare utilization, access to preventive practices of cancer screenings? What role does health insurance, acculturation, perceived racism, mistrust in healthcare, and healthcare comprehension play in assisting or hindering healthcare utilization? And what is the role of culture in that? So what I'll be doing for my dissertation is looking at that. I'm further analyzing the data set that we have by doing like regression analysis, using a sort of Anderson model to kind of lay that out. But I'm doing interviews to kind of data triangulate that information. Because again, we know quantitative data is great. That qualitative data really gives you the meat and the bones of what's going on, really provides you a way to talk about these information and really learn more. So I'm going to do 27 interviews to really learn about what's causing people not to engage in those cancer screening behaviors. So hopefully I'll have some information to report on next time, once I finish that research in a few months. This is what my framework looks like. But I am looking at acculturation, perceived racism, mistrust in healthcare, and healthcare comprehension. That's like what I believe to be from the literature and from what I've talked to as reasons why people aren't engaging in cancer screenings. So I'll be, doing my analysis with that, as well as using that to kind of have influence my interview questions with individuals from those housing communities. And that's what RDS looks like. You can kind of see, you can kind of match the referral chain. So these are the people who took the survey. You can kind of see, you know, if males referred females, and you can see if Native Hawaiians were referring Chukis. That's what that kind of looks like. I'm doing that analysis again right now. This is one of the referral chains that I worked on. Yeah, and that's it. So yeah, I just want to really kind of provide oversight of what we're doing. I know you all are doing great work yourselves and similar work, but our work and then the core is really just trying to work beyond the community, engaging in different research projects, but also just trying to ensure that community is at the forefront of everything that we do. You know, we say we're working with and for the communities that we serve. And we just try, we do as much as we can to include their perspectives and their voice in everything that we do, as well as the partnership grant does. Thank you.
Thank you, Mark, for this excellent presentation. There are a lot of details that you shared, and I'm very eager to see what questions people have. We will stop the recording here, and please just unmute yourself and ask questions.